Welcome, everybody, and thank you for taking your time to come and listen to this. You're not going to regret it, but I do know, particularly at the moment, how difficult it is to eke time out of busy schedules. My name's Jenny Froome, and I am a director of ASCEA. I have been a director since the beginning. Liesl de Wet and I founded ASCEA back over tea one day when we were lamenting the fact that people still really didn't quite get what supply chain management is, nor do they understand what end-to-end supply chain management is, and nor do people realize the breadth of industries and sectors that supply chain support, and also what incredible work is being done across this varied continent of ours. And one of our big drives is to make people understand, we as Africans all understand that Africa comprises 54 different, very different cultures, languages, and loads of languages, but 54 different countries. And when people refer to Africa as Africa, we need to educate people that there is more to it than just one country. The more we delved into this, the more we realized just what extreme excellence in supply chain management there is. We certainly experience different infrastructure challenges to many other countries in the world. We have different language capabilities, etc., etc. So to see the level of professionalism and excellence that is often intuitive is something that we felt very strongly needed to be spotlighted. And we've done that over the last 5 years with the incredible support of our judges, exceptional people like Leon Roth, who's with us on the call, and through the amazing submissions from organizations that are represented here today. But also, if you want to go on to the ASCEA website, you will see all the winners from the last 3 years, I think. And you can see the detail, you can see the absolute variety of industry that has submitted, that has been awarded. And I think it's a real education for all of us, even those, let's say, jaded supply chain professionals and those people who think they know everything about Africa. I promise you, you don't. And every year there is a revelation, one that normally blows holes in Leon's socks, as I think he's very famous for saying. But we've had some super things and really, really, really varied. We also couldn't do this without the support of our sponsors. We've got a very exciting addition to the sponsor lineup this year with Newlyn Group as a headline sponsor. And then the organizations who've been with us since the very beginning, Forte, Supply Chain Solutions, Bid Air Cargo, and DP World. As a not-for-profit organization, those of you who work in this space will definitely understand. We love what we do. We're passionate about what we do and how we do it. But at the end of the day, you need money to do it well. So we're very grateful to these organizations for their support. Then down, you'll see in the slide below, there is a list of partners. And again, this tagline that we have of by the industry, for the industry. Liesl and I are just two people. ASCEA is representative of an enormous profession. I always prefer profession to industry, but I stood to be corrected on that, and we use by the industry, for the industry. And the professional associations and bodies who support ASCEA and have done since the very beginning are invaluable to our existence and also to our survival. So it really is it's a community project, and that's something that I think supply chain professionals understand, is that everything happens using the best collaboration possible. So without any further ramble from me, I would like to introduce you to three exceptional individuals. You have Leon, Angelina, and Wilson. Leon was the head judge on these two submissions that came through. They're two separate submissions, and Angelina and Wilson will take you through the high level of them. And Leon will share with you what made them so special for the judges. And that's their big challenge, is how do you compare life-saving supply chains to financial saving supply chains? At the end of the day, it's not the industry that matters. It's the management of the supply chains and the excellence that is demonstrated there. How you demonstrate that to the judges is what they are expert at helping to get from you. So if you haven't submitted yet, we are looking for case studies, we're looking for projects. This is not about individuals. We know that a supply chain is managed by a team of people. And so if you haven't yet submitted, you have until the 30th of April to do so. We're going to put the link in the chat so that you can click on that and see what's needed to do. And if you think that your story is not worth telling or that we won't be interested, please try, because we are interested in anything that is making a difference on the African continent. So you never know until you try. And there are no hidden costs. There's no catch. This is purely so that we can spotlight supply chain excellence in Africa. So over to you, Leon, and thank you very much for your volunteer time and the outstanding job that you and the other judges do for us.
Thank you very much. I've been asked to just say just a few introductory comments about these two entries. As Jenny has mentioned, I was the lead judge. I'll kick off with VillageReach, Angelina. So Angelina is the superwoman of Africa, and you will see why. It is the entry of VillageReach. They were the joint winner in the category of humanitarian and the health supply chain. It was operating from Mozambique, but expanded into quite a number of countries. The complexities are huge across all these countries, and we know in supply chain, on-time delivery is important, 99% on time. If you world-class, the definition is above 98.2% on time, and they've reduced 30% cycle times. They've addressed 5 million people serviced. They deliver with trucks, drones, motorbikes across Africa. Just one example, one country, the DRC in the Congo, it's 98% is availability of stock and zero stock outs. They work through a network of 675 health workers. I'll let Angelina then talk to you more about the detail. On the other entry, which is CMCOMMS, Wilson operating out of Zimbabwe, it's also, they were Excellence Recognition Award in the humanitarian and health supply chain. And Wilson himself designed it, he implemented and has rolled out. It's all to do with falsified medicine, fake medicine. It's like grandpa powder you get, and they just put other rubbish powder in. People think they're buying medicine, but it's life-threatening, and how we control that whole supply chain. So they've expanded across Africa. They've received amazing accreditation in Zimbabwe, internationally, worldwide. He's a worldwide expert now on this subject matter, and that's great to see that. Anyway, best wishes, Angelina and Wilson. So Angelina, I think we've got to kick off with you. You're still on mute.
Thank you. Cindy, can you put the presentation on the screen and let me know if you can hear me properly?
I am sharing. Can everybody see my screen?
Yes, we can see it.
Perfect. Thank you.
All right. Thank you. Thank you, everybody. Firstly, good morning, good afternoon, depending where you are. Thank you, Jenny and Leon, for inviting me again. My name is Angelina Kumba, Senior Manager for Access to Health Product at VillageReach. To those who don't know, VillageReach is a non-profit organization that works with government and partners to strengthen access to essential health workers. Jenny will share the link of official website in the chat for those who like to learn more. So the journey I'm going to share today began in Mozambique. I cannot see the screen, Cindy, so I'm opening my deck here. Yeah. So the journey I'm sharing today began in Mozambique, but the broader lesson is about the country leadership, practical partnership, and stronger system design can improve the access to health. Cindy, I can't see it, but I'm looking at mine here, if that is okay with you. Can you hear me?
Yeah, we can hear you.
Yeah. Yeah, but I cannot see the deck, so I'm opening from here. If everyone can see it, that's fine. So I'll try to open one from here. Okay, so as I said,
yeah, we can see Angelica. We can see very well.
Okay, thank you so very much. So the gen I'm sharing today began in Mozambique, but the broader lesson is about the country leadership, practical partnership, and stronger system design that can improve access to health products across Africa. At the heart of this work is a simple reality. When health supply chain are stronger, health workers can serve, with greater confidence, community can trust the system, and people are more likely to receive, care they need when they needed it. So, as I said, we started in Mozambique, and this work grew over across 15 African countries. It started with the challenge, clear challenge, the problem that we wanted to solve: fragmented system, frequent stock out, expired product. So in Mozambique, a more structured transport approach through our Access Health Product Program, or TRC, helped improve delivery performance, achieving at least 99% on-time delivery, 99.1% in food delivery. In the case presented here, they also show contribution of about 30% reduction in lead time and the elimination of the stock. So that is why the impact is real and why we are doing what we are doing, because we really believe that strong supply chain mean more real goods access for the people who depend on them every day. So to see this experience made beyond our country, it helps to look how it's expanded Africa. So I'm on slide 3, Cindy, where is scaling sustainable outsourced transport. So now you can see on this slide that shows the journey in 2 parts. On the left side, it highlights what implementation looks like in Mozambique, where the model supported last mile distribution across 22 districts to 22 health facilities. It comes to 1,577 delivered and more than 87,000 kilometers traveled, over 1.2 million cubic meters delivered, and estimated 5.1 million people served in this initiative. On the right side, you see the map show the learning from Mozambique did not remain in one country. It informed broader technical support and adoption across Africa, helping expand the access to health products work through the TRC program in multiple countries. So the key message here is that Mozambique was not only a place of implementation, but also a place of learning. What started as a practical country response helped generate experience, tools, evidence that could support other governments exploring how to strengthen transport within their own public health supply chain. So before we look at the broader results, the next question is, what system challenge made this kind of approach necessary in the first place? So the next slide is why outsourcing in public health sector. As you can see that regular, secure and quality transport of medicine depend on having enough vehicle, the right people, and well-organized system behind them. In many countries, government faces real constraint in buying, operating, and maintaining that transport capacity at the level the system requires. So what you're saying is when transport capacity is strained, delivery become infrequent, stock out increase, and even the products available. Hello? Cindy, can you hear me?
Yes, we can.
Okay, thank you. I'm hearing back the echo. So as you can see, when transport capacity is constrained, the challenge delivery become even more infrequent, and your problem stock out increase. When the products are available, is even challenged. So that is where private sector transport partner can play an important supporting role, not by replacing the government, but by providing additional professional transport capacity that is aligned with the public health sector objective. The message on this one is that it's not that government should step back, is that government need practical options, including well-managed private transport to make health product delivered more reliable, especially at the last mile. Even when the transport capacity exists, it is not if it is not a well-integrated across system, it creates a serious inefficiency, which is what the next slide begins to unpack. Cindy, I'm now on the next slide. So this slide represents one question from a broader benchmarking and Cindy, which slide are you? I'm on slide.
We are on the several factors undermine supply chain.
Okay, I just wanted to double check that. So this slide presents one question from a broader benchmarking survey effort led by VillageReach to better understand how outsourced and private sector transport are being implemented in Africa. We did this survey last year, about 2 years ago. So this chart is only one piece of the analysis. It helps illustrate a bigger much picture point on how the system and function in practice actually. So the specific question looks at each commodity groups are being transported by private sector. That matters because it helps show where outsource is already being used, how broadly it's being applied, and where fragmentation may still exist across the supply chain. The message is that the efficiency problem does not come only from the lack of transport. They also come from how integration across system, when different products, partners, and delivery arrangements are not well coordinated. In those conditions, cost rise, resources are used less effectively, and supply chain performance becomes even weaker in overall. So this chart is not meant to stand alone. It is an example from the survey that points out the broader conclusion. Improving transport performance is not only about adding capacity, but about organizing the system in a more integrated and accountable and reliable way. So that is what makes the next slide even more important, because it shows more structured response developed to address those kind of gaps. So the solution is VillageReach. We said, okay, what do we need to put in place to make sure that we help the government in a more structured and organized way? The solution presented here is a structured journey with the first stage, exploration, where we talked to the government and said, okay, what do you know about outsourcing? What do you need about outsourcing? And we had this set up that helped the government to be ready whether they want to use any different type of outsource or private sector engagement. Then we come to the implementation package where we design, okay, what actually do you need to have in place when you want to adopt outsource in your public health sector? Do you have the tools? Do you have the system? Do you have the resources? And the next stage is to say, okay, do we have the skills, the management's capability to manage the outsourced? And lastly is around verification, where we said, is private sector actually adding value to this initiative, to the public health sector? So what this approach offers is more than transport execution. It helps establish structured performance measured and management discipline in a system that were previously fragmented. That is important because sustainable improvement depends on how the system is organized and managed, not only how the products are moved from one place to another. So let's look at the next stage on how that support continues through the implementation within the Ministry of Health. So the next slide, Cindy, you are on the access to health products slide, right? The access to health products supports ministry.
Give me a second.
Okay, so now I can see the slides. You are still on the why outsourcing.
Okay, let me just see if
You are a little bit far up. Okay, so do you want me to come back? I can see why outsourcing on the screen now. Can you move your slide, your sorry.
all right, so right now you've just gone through the solution.
Yes, I just already got through that. Can you go to the next slide?
I can't
So we pass to the solution.
When I'm in the, let me go to the next slide after that, which is the implementation.
Just a few technical issues.
Yeah.
Okay, so
There we are.
now,
Implementation.
okay, Cindy, I think, okay, so okay, all right, fine. So that's the next slide that I want to talk about because I just moved from the previous slide on where I was talking about the Can you hear me?
I can hear you, Angelina. Your next slide.
Yes, Angelina, we can hear you.
Okay, so as I said, now the next step is to see how the support continues through the implementation of the Ministry of Health. Now we are looking at the emphasis, what we support through the outsourcing journey. The focus here
is your results achieved. The next slide.
Yeah, so that's the slide. That's the slide. Don't move, Cindy. That's the slide. Okay.
Okay.
That's the slide. Okay, good. So the emphasis here in this slide, like we really want to make sure that, you know, the outsource is not a standalone initiative, but this should really be part of the whole ecosystem. So through this outsourcing journey, the focus is helping the government move from the concept to implement in a way that is practical, measurable, and aligned with the system needs. What's stands here is that the journey is not presented as a one-off intervention, but it's a process that helps the government strengthen oversight, improve performance management, and build stronger term system capability to ensure that okay, I think I need to take off my video. Can you hear me now?
Yes, we can.
Okay, I can't hear anything. Okay, now I can hear you.
Can you hear us now?
Yes, thank you, Cindy. Now I can hear you. So this slide now, what we are saying is like this also should not be taken as just standalone, but needs to really fit into the whole supply chain, to the whole system, to make sure that it really speaks to the end results. And what we are saying is that it should not stand alone here. It's a journey that is not presented as a one-off intervention, but it's a process that helps the government strengthen oversight, improve performance management, and build longer-term system capability. What that support in place, the real result became visible not only in the logistics, but in access and system performance in a broader way. Integration is not just to look at, okay, what is exactly that needs to be done on that particular process within supply chain, but you need the whole ecosystem. If the one transport mode is not working, what needs to be considered for them to make sure that you deliver the products to the last mile. So what we are looking at it right now is to go to this next slide is how outsource now is transformed the health access across Africa. Cindy, can you go to the next slide?
Done.
Okay, I can't see anything, but okay, all right. So the results here goes well beyond transport performance. Ministers of Health were equipped with tools, strategy, and technical expertise, and national systems were strengthened through transport strategy, a 3-pillar contracting, quality management framework. This presentation also shows expand reach and equity with improved product availability across 14,000 health facilities. We had reached 675 health workers across 15 countries in sub-Saharan countries, improved access to healthcare related to almost 111 million people. So the message here from the health community worker in Mozambique, where we started this project, shares with the, okay, thank you. We have received a court. Cindy, can you hear me? I'm getting in echoes.
Yes, we can.
Yes, we can hear you clearly, Angelica. Very clear.
Okay, thank you. I'm getting some blacks here. Anyway, so the presentation shows the expand reach and equity with improved product availability across health facility, almost 14,000 health facilities, 675,000 auto workers across 15 countries in sub-Sahara, where the access to health products we're supporting reach of over 111 million people. From the community health worker in Zambezia, the real people on the ground that experience that were part of this initiative, share a very important quote with us when she said, better transportation reliable means health workers can plan with confidence and community and can depend more on the system that's saving them. This is from the voice of the people that we are part of this initiative when we started working with the Mozambique government, implementing from the first time, adopting outsource in the public health sector, taking them stage by stage on how outsource should be implemented, what it needs. And again, this is a collaborating approach. It's not just a VillageReach standalone approach and come to say, government, you need to do that. It was a collaborated initiative from the start, really understanding what the government needs, but most important, to understand what is exactly that we want to solve from this. Outsource was just part of the tool that we used to reach the health communities in Zambezia, which was now replicated nationwide and now goes beyond to other countries to reach 15 more countries. Behind those results, in group of people and partners who have made this possible. So can you go to the next slide, Cindy?
Done.
I'm almost getting to my last slide. So this slide just recognizing the people that were part of this initiative. Okay, I can't see it, but I can. All right.
It's the team.
Yes, yes. So the slide recognizing the people behind the work and the broader network that helped to shape and sustain this approach. It reminded that, you know, system change does not happen through one person or one institute alone. Strengthening health supply chain requires technical expertise, trusted partnership, and long-term commitment to government-led progress. So that collaborating foundation is part of what makes this work sustainable. We had to make sure that the team on the ground had a good relationship working with the local government partners to understand the problem, to design a solution that actually served the problem. Is that the mother, the child, the last mile, is it getting the help, the medicine that they needed? So that brings me to the really forward-thinking question that what should be done next, looking ahead? Cindy, can you go to the next slide?
Done.
Okay, I think it's, all right, I can't see it, but I think it's okay. I can follow mine here. Forward. So then really thinking, okay, from everything that we have learned, all the experience that we have gathered, and now as VillageReach, you are asking yourself, so what is next? So the message is like, the next chapter is bigger than transport model. It's not just about talking about outsource. Outsource is just part of the supply chain. If we really need, it is now about helping the government redesign the supply chain function based on the context, performance, and sustainability. So that includes strengthening ownership, using strategic partnership where they add the most value. Whether the government decided to use the in-house transport or outsource, we need to be able to help to see, okay, is it actually adding value? Applying data, tools, and practical learning to improve a reliable access to health products, because that's the end goal. The children and mothers at the end of the last mile are getting the right help that they need. The goal is to build supply chain that are fit for the purpose, resilient, and people-centered. That is very important. That's why you see in VillageReach all our strategies, we make sure that they are people-centered. It starts with the people. We understand the problem, what is exactly that is affecting the people. So this is an important shift in emphasis. The focus is no longer about promoting a single approach, whether it's outsourced, whether it's digital solution. We need to make sure that, you know, it covers the whole ecosystem, but not only supporting government okay, thank you. This is an important shift in emphasis. The focus is no longer promoting a single approach, but on supporting the government to make better system decisions that improve access over time. So in that, the broader message on this journey, we are saying that stronger supply chain are built when access, stewardship, and people remain at the center of the strategy, of the center of the process. Now, to come to the end of my presentation, apology for all this technical reason. I hope you really get the message from this, what we are trying to convey. Thank you very much for the opportunity of this journey. It is a story that began in Mozambique, outsourced in Mozambique through a program, access to health products or TRC program, but it's a broader message about how country leadership, practical partnership, stronger system design can improve access to health products across Africa. But most importantly, this work matters because behind every improvement in the supply chain is a person, a mother, a child waiting for care, a health worker serving community, and a system trying to respond more reliable. So with that, thank you very much. So I'm ready to answer your question. And again, apology for the technical issues. Cindy, I think that was the end of my presentation.
Yeah, I've stopped sharing, Angelina.
Okay. Do we have any questions for me?
Many thanks, Angelina. I think what we're going to do is we're going to whiz straight over to Wilson because time is not on our side. So let's let Wilson do his. I have WhatsApped you a couple of questions so you can be preparing your response, and we will, Wilson, record time. It's not the time, it's the content. So no challenge, but over to you and to the brilliant work you're doing. Two things I want to say. One is that what VillageReach do so well is education. They understand that the human being in the supply chain is still incredibly important. And I think that the message that Wilson is going to share with you now is going to make all of you who have not really thought about the safeguarding Africa's medical supply chains, is going to make you look at things in a very different light. So over to you, Wilson. And thanks again, Angelina.
Thank you very much, Jenny. You yourself, you are an inspiration for the work you have been doing in the continent over the years. My regards to Cindy for a good work that she's doing, Leslie in absentia, and Leon, as well as let me acknowledge VillageReach, Mr. Mkwashi here, and Angelina. See, when you mention VillageReach, Angelina, you go beyond the last mile. You're actually in the village. You are with the people where things are happening. And you understand in the village where things are happening, that's primary health. And in low resourced settings, when we manage the preventative side of health, we win half of the battle. So thank you. I'd like to acknowledge also people present, the Pharmaceutical Wholesalers Association of Zimbabwe, the chairperson is here, and other team from Zimbabwe to support me. Thank you. My name is Wilson Chandomba. I am an African who lives in Zimbabwe. I'm not a Zimbabwean, I'm an African. To me, Africa is a country. I'm passionate about access to quality, safe, and effective medicines. These three variables, quality, safety, efficaciousness of medicines and medical devices is still quite a challenge. So the three issues about our submission was we introduced good logistics practices within the supply chain. Then we received local and global accreditation. We increased awareness to substandard and falsified medical products. Next slide. Right. Before to who we are, I just want us to understand that there is a recent report last year, a Guardian newspaper said WHO says one in 10 out of 1 in 10 products in the low to middle income country, including Africa, is falsified. That was in 2017. But the recent reports are actually saying 1 in 5. That was in Guardian newspaper of last year. Then 2 months ago, on oncology products, they're saying 1 in 6. So the situation is getting even much worse. We are actually consuming substandard or falsified products, a lot of them. The problem is growing. Anyway, who are we? CMCOMMS is a professional health and humanitarian supply chain organization. Our mission is to improve the quality and integrity of medical products distribution through strict adherence to good storage and distribution practices, especially in remote and undeserved region. Good storage and distribution, these are practices. One of the problems that we found, especially as Africa, we have got a GSDP guideline, but in theory, not in practice. So when we talk of practices now, by definition, GSDP is about adequate control. How adequately are we control the end-to-end supply chain? So our mission is to ensure that across Africa, we've been to Somalia, South Sudan, Cote d'Ivoire, Tanzania, a lot of countries where we are promoting GSDP not as a guideline, but as a regulation. Next slide. So the challenge, we've got serious health risks caused by substandard and falsified medical products, weak supply chain, untrained logistics service providers. There you can see a recalled a grandpa. Leon, Leon. Sorry, there's somebody speaking. Can they? Hello, there's somebody speaking. Can they mute?
I think they've muted. Can everyone just check that their mics are muted, please?
Everyone else is now muted.
All right. So what is the challenge? We've got serious health risks caused by consuming substandard and falsified medical products. I want you to imagine something. You are suffering from some of these conditions. Maybe you've got a high hypertension, high BP, you are diabetic. You then take your daily dose, but that dose is substandard. It cannot maintain your systolic or diastolic reading of your hypertension, or your sugar levels cannot be sustained. And you actually thinking you're taking the correct product. The consequences are actually fatal. And this was an example of previous years of grandpa. Right now, we actually have got citrus soda sachets that have been recalled among many other products from East Africa. Just recalled because they are substandard, they contain certain contaminants. And our supply chain is weak. I think we have seen a lot of smuggling of products. I think those that know right now at Bedbridge, nothing is moving. There's so much searching. Why? Because of a lot of movement of substandard falsified products being sold in streets across Africa. Then we've got untrained logistics service providers. So this problem is still continuing, and we need all hands on deck. Next slide. Right. So when we identified the problem, we saw the challenge, we then identified the problem. Logistics service providers handling medicines without due care and diligence. Remember, one of the weakness of the WHO GBT tool. When I say the WHO GBT tool, I mean the one that controls regulatory authority, MCZ, SAPRA, and so forth. It focuses on licensed establishments. Here, I mean manufacturers, they are licensed. Wholesalers, they are licensed. And the farmers are licensed, but they forget that there is somebody who is physically moving the product from the manufacturer to the wholesaler, from the wholesaler to the distributor, which is a logistics service provider. Those are the problems, and they are not licensed. No formal regulations for handling medical products in transit. We had even a point where we didn't even have those regulations to govern the logistics service providers. And illegal importation of unregistered, substandard, and falsified medicines. I think those like in Zimbabwe, for example, or Zambia, Mozambique, we've got a lot of problems of bronchlia, which is being which is unregistered in our territories, but is being smuggled and being abused by youths. So these things are still a challenge. Next slide. What is the root cause now? What is really causing this? Our assessment showed that storage and transport conditions are often not aligned with the product requirements. For example, oxytocin, the requisite temperature is +2 to +8 degrees, but you can find one establishment, the product is stored at 18 degrees, or during transport. And we know our border areas like Bedbridge, Chirundu, Plumtree, they are very hot. How do we manage such product in transit? Logistics staff lack formal training on pharmaceutical handling, especially the logistics service providers, the drivers. They are just moving products, yet they are not trained. When we talk of training, we are talking of capacitating the drivers to understand the risks of contamination, for example, cross-contamination, temperature escalations, cold chain. Enforcement of regulation is inconsistent or missing. When we talk of these logistics service providers, how are we giving them business? Because the regulation says they should still have a GSDP contract and they should prove their compliance. But most of the time, we are just using the transportation without following proper procedure. Next slide. Right, we cannot continue talking about problems. I think those that know me, I'm not, I don't like to talk about problems. I like to talk, I'm more solution oriented and we demonstrate our solutions. So what we did is we analyzed Zimbabwe. I think those that know, pharmaceutical industry in Zimbabwe started in the 1960s, very strong, robust. I think MCZ in the next few weeks will actually be the first African regulator to be on MO level 4. But we had a weakness that time, I think around 2017, where our supply chain had gaps. So we wrote to MCZ as a strategic imperative that we need to introduce and enforce good storage and distribution practices within end-to-end supply chain, especially targeting the transporters, those that are moving the products, those that are smuggling the products. We submitted a detailed dossier to MCZ, which was accepted and implemented. You can see as a confirmation of that letter in 2021, where MCZ incorporated good storage and distribution practices. When we say GSDP, we are talking about adequate control of everything from the time we pick the product up to the time it is dispensed. I think there's another definition of substandard product, which I fear most. You'll have a product that is passed when it's released by the manufacturer, comes to the border, it's sampled by the regulatory authority, they do their test and passed and released now into the warehouse. But from the warehouse going to the last mile now, that product could be mishandled because there are no any more quality controls between the national warehouse or the warehouse and the last mile. People may end up consuming the substandard products. But with adequate control at all levels, we manage that risk. Next slide. So implementation steps. We then developed and launched a medical logistics practitioner training program, which we rolled out a lot. I think in Zimbabwe alone, we have trained more than 1,000 people on the medical logistics. When we talk of medical logistics, we are talking from the time you pick up a medical product from the manufacturer, from the time you pick up a medical product from the manufacturer, how do you contract a transporter, a freight forwarder, which choice do you use, and what adequate controls do you use? We talk of customs clearing up to last mile delivery. So every aspect of logistics, we index it to GSDP and adequate control. So we are still perfecting that program. So we rolled out cohorts of those programs in Zimbabwe. You can actually see on those photos, we had people and even took people to a port of entry. Because sometimes training these days, people have got knowledge, but what they don't have is application of that knowledge. So we had to go to a port and demonstrate what we're talking about. So we are still continuing with the capacity building and advocacy. In our submission to ASCEA this year, which we are finalizing, you will actually see us in Somalia, in Hargeisa, in Mogadishu, in Garowe. You will see us in Tanzania. You will see us in Rwanda. You will see us in South Sudan. On the ground, you'll see us in Kenya, in Bungoma. You'll see us in Kenya, in Nakuru, offering these practical capacity building programs. Next slide. So because of this, we got a local and international recognition. We are accredited by the Pharmacist Council of Zimbabwe, CPD Group, the International Pharmaceutical Federation, FIP, and we are recognized by MCZ and a number. And we are an accredited implementing partner for the PTD Step 2.0. And further, we are also now, because there's no PTD coalition, we are part of the PTD advisory group, and we are in the technical working group for substandard and falsified medical products for the continent. And recently we become an ambassador for Fight the Fakes Alliance. Next slide. So in terms of proven results, we improved prevention, detection, and response to substandard and falsified medical products at ports of entry. I think you can see in Zimbabwe, a lot of reporting is being done where smugglers are being caught because of this awareness. We also, because of this, we ended up implementing projects in Namibia, Uganda, Cote d'Ivoire, Niger, Somalia, South Sudan. We are now leading International Association of Public Health from the Southern Africa region. We are guest lecturers at in health supply chain at Magatho Sekafasto University, and doing a number of things. I think in our LinkedIn, almost every other day we spoke about the prevention, detection, and response to substandard and falsified medical products. We work closely with AudaNEPAD and a number of things. Next slide. So this was a collaborative team effort. Me, I believe in collaboration. I believe together, each and everyone achieves more. So it was because of CMCOMMS and our team. We worked with MCZ. We worked with Shipping and Freight Agents of Zimbabwe. We worked with IPHL, Pharmacist Council, FIP, Parenya Group, PPDD, a lot of people. And even up to now, we continue working, collaborating. That's why I say I'm an African. Every other country in Africa, we try to help, to assist, to ensure that we secure our borders. Next slide. So the way forward, which we have, some of these have been even overtaken by the events. We are still driving continental expansion and will be showcasing what we have already done in the continent. And we continue doing webinars, magazines, And we have even since joined SAPIX. We are now a member of SAPIX, where we are also pushing this agenda, collaborating with people like B-Skilled, VK Academy, different people, and even involved, because we want to continue making noise. I think in Zimbabwe we appear on national television, we appear in newspapers, even in continental news magazines, talking about substandard and falsified medical products. Next slide. So I would like to thank you. And on my parting shot, we are and will continue being part of ASCEA because it gives us a platform to talk about this subject, because everything starts with awareness. Are we aware of the dangers? Once we speak about awareness, then it comes to action. So we'll continue to talk about this subject of substandard falsified and make a difference. Thank you very much. This time, thank you, ASCEA. Thank you, Jane, our host, Leon, Cindy, and Angelina. Thank you very much. Over to you.
Well done, Wilson. That's great. And thank you very much for your time observation. We really appreciate that. We've got time for a couple of questions, one of which I think let's do to Wilson first while it's fresh. You've been asked about the relationship between your system and what does it have? What's the relation to the GDP standard? Are they duplications? I said that I think they're complementary rather than duplicatory, but you're the expert, so perhaps you'd like to answer that one for us.
Thank you very much. It is actually the same system, and what we just did is that in the past, I started good distribution practice in 2002. And then in around 2010, 2011, they had good storage practices. Our system is just a combination of both, because when you are in the supply chain, you need both the distribution and the storage. Because as you are distributing in transit, you are also storing. So our system that we are using is actually a WHO guideline, which is good storage and distribution practices, and a combination of both. We the piggy bank the stricted standard. If it is PIGS, if it is EU, or if it is standard, such that even if you are operating at 80%, still your threshold for risk is higher. So I would say it's the same standard, but combining good distribution practices and good storage practices.
Excellent. Has anybody else got any questions for Wilson while he's got the floor? Otherwise, we'll whiz over to Angelina. Wilson, if you just want to have a look at the questions, Charles is having a full-on conversation there about GDP. Perhaps you'd like to have a look at it, and I will. You can share with me your answers, and I can then distribute them to everybody who's here, so that we don't get into the, not the weeds, because that's negative, but we don't have to get into the nitty-gritty of it. Angelina, are you still there? Can you still hear us?
Yes, Jenny, I'm here.
Excellent.
Oh, Norman, since you have a question, you just raise your hand.
Yeah, Norman.
Okay, thank you very much. Mine is not a question as such, but it's just to want to commend Mr. Ndoma for the good job, and Mr. Ndoma and his organization, the good job they are doing in Africa. I think the biggest challenge which we are facing as a continent is that the substandard and falsified medicine industry is quite huge, and it's quite huge. And at the same time, we have got the mandate to ensure our populations are safe. So I think your objective as an organization, they are quite noble, and I think as Zimbabwe we've been quite supportive in terms of information dissemination on our workshops, on our conferences, and so forth. So we really want to commend you, and Yeah, I think more needs to be done. More needs to be done for our population to be safe from substandard and falsified medicines. I thank you.
Thank you, Norman. And I think that that's very true across industry as well. You know, in South Africa, we've had the case with the counterfeit tobacco trade. We need to talk more as supply chain people. And I think Wilson posted this week something about weak supply chains and counterfeit drugs, and that they should not be separated. They are part and parcel of the problem. And the more that we talk about it, the more people understand and the more aware. Ordinary people like me are aware that there is this that goes on all the time. I was first exposed to it with a student talking about the traffic going from Nigeria through Burkina Faso of counterfeit drugs, and that was a real eye-opener. So thank you very much, Wilson, for opening our eyes, for doing the work that you do and continuing to be the voice that champions these standards, which with whatever other standards there are. I know that what you do and what your organization does is collaborate and believe in community. And I think that those are very exceptional attributes. Did you want to say something? Your hand is up. And then we've got 2 minutes for Angelina.
I'll do it for even 30 seconds. I saw a comment just to understand. You see, I've been in the pharmaceutical industry for more than 28 years, and we've practiced GDP from a practical point of view. By definition, GDP by definition is a part of quality assurance and is about adequate control of all activities within the supply chain. Good distribution. Then that WHO guideline defines distribution almost as all facets of the supply chain. So there's no contradiction. How do we measure? We only know with your controls. For example, in your country, if we see that they are smuggled products, it means at the port of entry, there are no adequate controls. So we then say, how do we control adequately at the port of entry? How do we control adequately? So it's basically you're just doing maybe our highest risk. How do we increase the adequacy of our controls? That's GDP in action. Thank you.
Thank you very much, Wilson, and succinct as ever. Right, Angelina, over to you to answer that question I WhatsApped to you, which again was from Charles, who's asking about what has been done to introduce the VillageReach system into South Africa, and if it has, what level of success has been achieved. And that's South Africa specifically, not Southern Africa.
Angelina, you are on mute.
Well done, Leon. Thanks.
So for the VillageReach, thanks for the question. We are not okay. South Africa, yes. So for South Africa, we not have implemented a full VillageReach. No, I'm not on mute. Can you hear me? I can hear you.
Sort of. Your network's not great.
Can you hear me?
Yeah, we can,
I
Angelina.
Can hear you.
Jenny, maybe I could come in for Angelina.
Hello?
Yes, thanks, Tapiwa.
Hello.
Hi, Jenny.
Jen can hear you. Anyone here?
Angelina, Tapiwa's going to answer for you. Angelina, Tapiwa's going to answer for you.
Full village. Oh, thank you. Thank you. Okay.
Go, Tapiwa.
Thanks. That's a good question, and it's something that we have given a lot of thought to, and we have ranked the countries that we prioritize in terms of the interventions we undertake based on epidemiology. And that's why we focus on Mozambique, on DRC, on Nigeria. And South Africa performs well, maybe not optimally, but better than a lot of the other countries which we then prioritize. All this to say, we have not actively sought to work in South Africa, as we have directed our resources to those countries where there is a higher need. Thank you.
Perfect. I think I'm right in saying that the different levels of the way countries are recorded that need the most help, and this is very simplistic, but South Africa is still considered to be very strong with a robust health system. So it's something that we don't hit the radar of a lot of the implementers, if you like, which is unusual, that's difficult for us living here to really register that, because we know that we need help too. Okay, so Leon, anything to wrap up? We're slightly over time.
Yeah, so I'll use Wilson's, for those late joiners, I was the lead judge for these two entries. If I can use Wilson's term, he's a man from Africa like myself. And what gives me a kick in life is that if we can do something on the African continent, that we are outperforming the Americans or the people from Europe that always sometimes think incorrectly when South Africa are not so smart. Let me just give you an example about the complexities. Last year or the year before, we had an entry from Cameroon also distributing medicine, just like these two entries. And it was online judging. And one of the judges said, but all your records are handwritten. Why don't you use a computer program? And the presenter said, you guys don't understand. 95% of the area wherein they operate, there is never electricity, no electric. And they've got to actually chop with a big cane knife a path through the jungles to get this malaria vaccines to them or whatever. And that's why I say Africa has got complex problems and they've got great solutions where the rest of the world can hear from us. Another last example. Some time ago, there was a presentation to a world body in the rail industry. And a director of British Rail said that what you guys have done in Africa, we've been trying to do in the United Kingdom for 28 years. They could not achieve it. So congratulations again, Angelina and Wilson. My definition, you people are world-class and example of the rest of the world. And thank you for your presentations. Thank you, Jenny, for organizing. And thank you for all the people that have logged in. I wish you well.
Perfect way to close off. And remember that the presentation has been recorded. We will be sending it out. And thank you all very, very much for taking the time. As I said at the top of the webinar, we know that it's an expensive commodity for all of us at the moment. So keep strong. It's a challenging profession to be in at the moment. I almost prefer before COVID, when no one understood what supply chain was all about. But just know that we know that you are all helping to keep the world turning. So thank you all very much.
Thank you for having us.
The dinner.
See you at the ASCEA 2026 Awards in Sandton.
Thank you, everybody. Thank you. Take care.
Thank you very much. Thanks.